This conference will now be recorded.
Okay. Sorry, one sec. Privacy. Great. Okay. All right, so this is my first case. We unfortunately don't actually have a radiograph on this patient, so I'm going to use the Scout. We can see here that the patient has an abnormality in their upper mediastinum along the right side, and our pretend lateral from the Scout shows that it is in the anterior part of the mediastinum. So we are dealing with an anterior mediastinal mass, and obviously as this is a Scout, we do have a CT. So this was the initial CT that this patient has. I'm going to tell you this patient is in their late 20s, early 30s. And we can see, corresponding to what was on that Scout radiograph, a round mass in the anterior mediastinum, sort of in the location of the thymus. So it kind of brings us to our anterior mediastinal mass differential, right? So pretty much regardless of age, most people can get lymphoma, right? This doesn't really look like lymphoma. If I were to drop an ROI in the middle of it, it looks relatively fluid density. Sorry, there's like a bunch of ROIs here, but relatively low density. There is this one little punctate calcification associated with it. So both of those would be unusual for a untreated lymphoma, which this patient has had no treatment. We did do, besides lymphoma, right, in a young person, somebody in this age, we always think about germ cell tumors. And then usually as patients get a little older, we also think about thymic problems, right? So this thing looked predominantly cystic. So we ended up getting an MRI to evaluate it. And we can see on the T2 imaging that this thing is predominantly T2 bright pretty uniformly. On pre-con T1 imaging, we can see some little speckled areas of T1 in the middle of it, which may imply that there's, I don't know, either blood or proteinaceous product, something else. And then we did a post-contrast imaging as well, which shows that there is a little bit of enhancement around the rim of this, nothing in the middle of it, but some areas of enhancement. And then finally, we also have a follow-up contrast CT, which kind of goes along with what we saw in the MRI, where there's still that little bit of enhancement and that one little punctate calcification. So this got removed surgically, and while it was predominantly cystic, the final pathology did find some sebaceous glands in it, and so this turned out to be a mature teratoma, right, which is sort of what we expect in the differential for somebody in this age range for an anterior mediastinal mass.
So Maya, I have a question. This comes up a lot. So like we don't do MRs for mediastinal masses usually in this location because if it's not lymphoma, it's coming out pretty much.
Right. Yeah.
Unless it's a purely benign cyst. So
Yes.
Is that something you routinely do, MR? I mean, I know some surgeons, our surgeons just, they don't want it. So I'm just curious, is it something you do routinely for your mediastinal masses in this location or only in selected cases?
I think it's usually a little bit more selected cases. Because this one on CT was mostly low density, we were like, well, maybe it could be a pure cyst. I think the MRI sort of showed us that there were some enhancing components to it, which made them more convinced that they were going to take it out. But yeah, if this was if this had not been low density on CT, this would have realistically just come out. Unless we thought it was lymphoma.
Sense.
Yeah.
So what did you say the histology showed that there were some?
It showed sebaceous glands sort of in the wall of it, which would be very unusual for any other thing arising in this area. Basically stuff that we should see normally on skin. So, yeah. All right, and then I have one other case which just came up. So I'm going to start with this patient's older study. So this image that I'm showing now is from a fairly recent PET CT from a few months ago. This is a patient who has known metastatic renal cell carcinoma. We can obviously see numerous bilateral pulmonary nodules and probably some masses as well. So pretty extensive metastatic disease in the lungs. Because of that, the patient was put on nivolumab. for treatment of these metastases as well as metastases elsewhere in the body. And they came in a few months after this with respiratory failure and got this CT. So I think the concern was mostly for pneumonitis related to their medication, which we do see some findings that are pretty convincing of that or suspicious for that, right? We see some very clear peribronchovascular consolidations and ground glass opacity, particularly here in the left lung. You'll also see that as I'm scrolling through, a lot of those lung nodules that we saw before are much, much smaller. So medication's working, but is also causing some problems. But there's something else going on here as well. I'm just going to slowly scroll through here on lung windows. So as we can see, as we come down, there's this large area of consolidation in the inferior portion of the right chest. There's some pleural effusions. But if we look closely at the airways, there's something else a little weird going on. So trachea, main stem bronchi, if we focus on this right side, so we come down the right main stem bronchus, the first branch we expect off is going to be our right upper lobe bronchus, which is this here, right? Which is not going in the location we expect it to go. It's going inferiorly into that area of consolidation. And then we come down bronchus intermedius. There's our right middle lobe bronchus and our right lower lobe bronchus. So it looks as if this patient's right upper lobe has moved, has essentially torsed down into the inferior part of the patient's chest. And just going back quickly to their prior, this was not the case on their prior exam. Trachea, right main stem bronchus, here's our right upper lobe bronchus going exactly where we would expect it to go. And then bronchus intermedius, right middle lobe, right lower lobe. So because it looked like that right upper lobe is now in the wrong location, and there's a large amount of consolidation in that right lower lobe or right upper lobe, which is now in the lower part of the chest, we raise suspicion for possible infarct, right? When torsion like this happens, you can get either usually venous, but also sometimes arterial infarct. So we did a CTA the same day. And this is that study. So here's our pulmonary artery, right, going into that right upper lobe, which is still in the same position. Arteries, I think, look pretty well patent throughout, so probably not an arterial issue. But if we take a look at the veins, we can see here's our right superior pulmonary vein, and there's this branch of it that gets very, very narrowed right in that area where that torsion is likely happening. The other branch of it actually, I think, looks fine. It is patent throughout. So I would be suspicious that there's at least some diminished flow through that one pulmonary vein, which may be causing all of this airspace opacity. But I wanted to bring this up because I don't know that I've ever actually seen a lobar torsion not in the setting of like prior surgical or mechanical intervention, which this patient didn't have.
We had one here a long time ago, and I may have shown it on the webinar. I can't remember. It was like 10 years ago, of a patient who developed a pneumonia and a pleural effusion, and somehow it flipped the lung over. Because I remember talking to the surgeon, he'd never had any surgery at all.
Yeah, same with this patient. But yeah, it's possible that the pleural effusion preceded this, and so that may have led to this happening. But yeah, got some nice twisting vessels in here, which is another good sign, although harder to see on the non-con. All right, those are my cases.
You can see it's another twist on the theme of torsion.
Ouch.
Yes. Love
All
it.
right, David, you just volunteered yourself to go next.
I'm going to jump over to a different computer, but I'll be right back.
All right.
Okay, can we see a CT scan?
We can.
This person has widespread ground glass abnormalities, some reticulation, and some mosaic attenuation going on. So not a bad pattern for hypersensitivity pneumonitis, but this is Sjogren's syndrome, and there are a few cysts. So here's a there are a few cysts, thin wall cysts like this, which goes with Sjogren's, probably some light chain deposition that's leading to some macrophage activity that ends up excavating the lung like that. But, you know, in the setting of hypersensitivity pneumonitis, cysts, you can also see cysts like this. So, you know, I encountered this pattern. I think this looks like HP to me, chronic hypersensitivity pneumonitis with some mosaic attenuation, and there were exploratory views that did show that there was air trapping, that this lucency is really air trapping. And cysts can occur with that, but this is Sjogren's. So, you know, I don't think I've seen the mosaic attenuation at this extent before with Sjogren's syndrome. I don't know, Jeff, have you?
No.
And it's possible
I
this
mean,
person
they can get, I've seen bronchiectasis with it. I've seen large airways disease, but I don't recall seeing isolated air trapping as a.
and you've
Is there any
you've
possibility the patient has both?
yeah, it's possible that there's both. You know, patients are allowed to have as many diseases as they want, but the diagnosis so far is Sjogren's, and we don't have lung pathology. So, you know, somewhat ambiguous findings here, but you know, the cysts would fit with either. The mosaic, I think, points me more toward hypersensitivity. Okay, let me show you another case in which the finding was cysts. Can you see a fresh radiograph?
Yes.
Okay, so there's a staple line up here, and this is the result of a previous pneumothorax that this person had. Let me show you CT on this person. And this is the time of that original pneumothorax that led to that stapling of a bleb in the apex. But the interesting blebs are down here in the bases. There are a few of them, and they have sort of strange shapes, including this lenticular shape here, and hugging a you know, a cleft in the lung here. So they like to be up against septa and veins and things like that. And this is, if we go on down into the abdomen, we find that there is a right kidney tumor, which on some enhanced CT scans lit up. So this is very bright here, consistent with a renal cell cancer. It's not been biopsied as far as I know, but there is a right kidney tumor. So this is all Birt-Hogg-Dubé, and with a strange shape to the cysts, including some lenticular ones, and the cysts often hugging septa and things like that.
Yeah,
Okay.
sometimes they're called floppy cysts. I like that term.
As in floppy disks. Yeah, okay. Got it. And
Most people don't know what those are, I bet.
This person's currently in the hospital with another pneumothorax. That's why this case came to our attention.
You know, David, it's my experience, it may be selection bias, but I suspect they have higher rates of pneumothoraces compared to some of the other cystic diseases because they have a tendency to have their cysts very close to pleural surfaces.
Yeah, right. Okay, and here's a case of a person with lots of lung disease and lots of distortion. Here you can see the traction on the inferior accessory fissure causing juxtaphrenic peaks on both sides, reflecting upper lung volume loss. Pretty symmetrical pattern, very low lung volume here. And this is a case of progressive massive fibrosis, this symmetrical scarring in the lungs along the posterior aspect of the major fissures. And then we have some interesting lesions in the bases here. We've got some very nice examples of the galaxy sign, these little cluster of these tiny little nodules with a denser center. So very nice galaxies down here. Now, the history is ambiguous. This person is an artist who has worked with ceramics. So there is some exposure to kaolin clay, which is rich in silica, and it's very fine material. So that would be a good source. But it sounds to me as if his exposures from the history that I was able to obtain weren't that great for that. And let's just look for lymphadenopathy, which might be helpful. There is lymphadenopathy. There are some mediastinal and some hilar nodes, and on some contrast studies, we could see the hilar nodes more clearly against the contrast column. And there's subcarinal lymphadenopathy here, but there's no calcification in the nodes. A lot of calcification might point us again. So the nodes, this could be sarcoid from the nodes. Person doesn't have a history of documented sarcoid, but really hasn't had a workup of this lung disease. And I don't think that I've ever seen this galaxy sign in silicosis. So that really points me more strongly to sarcoid here. But we really don't
Yeah, I
know
agree.
with this
I
guy.
agree. This looked like sarcoid. The nodules in silica usually aren't this shaggy, and especially, I mean, this perfusion is so high, you don't usually see that unless someone's a sandblaster.
Right. And you would expect also to see some upper lung nodules here. And the nodules in
Right.
silica, as you're saying, are usually pretty discrete. I mean, they're fibrotic, so they really stand out. Um,
Right.
these are fuzzy and sort of cloud-like
Yeah.
conglomerations here.
And the
So
stuff around the airway in the left lower lobe too is very shaggy. Looks a lot more. I mean, I would have called this sarcoid regardless and been done with it.
short circuit the whole process. You don't want to perseverate, huh? Perseveration
No.
is the fun. Okay.
Yeah. If he had the icing sugar lymph nodes, it'd be a slam dunk, but we don't have that.
Yeah. Or Judd Gurney used to call the putty nodes in sarcoid this sort of vague whiteness,
Hmm.
see, not dense little
Yeah.
nuggets of calcium. Okay, so another person who is short of breath and hypoxemic is this person with chronic liver failure who has some mild basal consolidation. It's hard to know. We only have a few weeks of imaging on this person, so I don't know how much of this is acute and how much is sort of permanent shape to the lungs. But on CT, the interesting finding is that he has a number of vessels that extend all the way to the pleural surface. And for instance, here we see these vessels going all the way out to pleura. And this is meaningful here when you see it anterior like this, not in the scrunched parts of the lung where there's dependent atelectasis that can sort of force the vessels against the pleura. These vessels are volunteering to go out to the pleura. That's a very good sign for hepatopulmonary syndrome. So this person has CT findings that go with hepatopulmonary syndrome and then definitely has hepatopulmonary syndrome. Again, we see vessels touching the pleura in non-dependent parts. So back here, it's a little ambiguous, but up here, it's clearly unweighted lung and the vessels really are reaching out to the pleura. And we see the same thing on the other side as well. So this is hepatopulmonary syndrome. The heart's kind of big. They do the workup looking for shunts. So the shunt in hepatopulmonary syndrome is really, the capillaries are very dilated. So normally the capillaries are small enough that the red blood cells are kind of banging up against the edges as they go through. And that means that the diffusion distance that oxygen and carbon dioxide have to cross is pretty small. So if you want your red blood cells right up against the capillary wall so you don't have a lot of serum for the gases to have to diffuse through. If those capillaries dilate, then hemodynamically, the red blood cells are going to stream down the center of that capillary, not near the edges, and you'll have a cuff of serum that prevents gas exchange. And the red blood cells will then emerge from the other end of the capillary into the venule, and they will not have had much occasion to pick up any oxygen. So that's why the people are desaturated and they're hypoxemic. So it's really the capillary dilation, and then accompanying that is this macro phenomenon of having the blood vessels that are supplying those capillaries get big too because of the torrent of blood that's shunting through those dilated capillaries. So the vessels feeding them, which is what we're seeing here, are fat. And some of these are veins. These are dilated veins downstream. I think the ones that are in the septa here are veins. So when you see vessels touch the pleura and you've got somebody with liver failure, you're probably seeing the radiographic findings of hepatopulmonary syndrome. So, I saw this on CT, and then the history is hepatopulmonary syndrome and hypoxemia. And then Sudhakar also picked it up, just from the imaging. So this is a case where it's fairly pronounced, well pronounced with these vessels going all the way out. Okay, that's all I have.
All right. Great cases, David. Thank you. Okay. I just have two this week. I think David will like both of these. Things we've discussed in the past. Let's see. All right, so this first patient is a young man. You can see my screen, I hope. It says it's still sharing. Let's see. There we go. So you can see on his radiograph, on the frontal radiograph, that his lungs are not normal. The right lung is small. It's kind of hyperlucent. There's these strandy things on that side. Left lung is a little lucent in the base, and maybe some hyperinflation. Here's the lateral. So not so hyperinflated on the lateral, but you can see that, again, that kind of little streaky things going on there. So the history with this guy is he was born very premature. I don't know exactly, but it was very premature. And he's in his 30s now at this point. So here's the CT of his chest. And you can see, first of all, he's got a stenosis here of his trachea. So presumably from tracheostomy or intubation a long time ago. And then he's got this heterogeneity of his lungs, and he's got these low attenuation areas. He's got areas with larger vessels. So a nice mosaic pattern. You can see the right lung is small. It is developed normal. There's an upper lobe, there's a middle lobe, there's a lower lobe, but the lower lobe is quite small. There's bronchiectasis. And then I don't see any real cystic spaces. I think these are just either emphysematous or hyperinflated areas, probably hyperinflated, given that it can still make out the lobular architecture. So then I know the names keep changing. This, I mean, we would have called this bronchopulmonary dysplasia, but apparently there's specific criteria. So, or it's chronic lung disease of prematurity, but effectively the same thing. The lung develops normally, but then gets injured early on in life and then has a bunch of problems with it. So I suspect he would be prone to maybe recurrent infections because of the bronchiectasis and air trapping, but we don't see this much anymore. I haven't, at least, but I know David's shown some in the past. But David, is this in keeping with what you've come across in your practice?
Yes, when I was first shown cases of this in adults, I thought, this is not, what does this have to do with this, bronchopulmonary dysplasia? This is Swyer-James syndrome because of all the air trapping, and so all the other cases have conformed to that. But those are the findings. It results from prematurity. It's not really dysplasia. I mean, it really,
right,
yeah. But so I think the name was misleading, but it's basically a lot of air trapping and a lot of airways disease. So
right, yeah, I like chronic lung disease of prematurity. That sounds somewhat better.
I saw that term this week too in some publications. So I'm glad they've come up with something that actually gives an accurate description.
Okay, yeah. All right, that's that one. And then this is a case of something I have been waiting to see, and it may or may not be related. So you can see on the sagittal here, there's no question what the diagnosis is, but there's beautiful ankylosis of the thoracic spine. You can see the fusion here posteriorly. And I didn't show, but this patient's sacroiliac joints are fused solid. So known ankylosing spondylitis. And the reason I came across this was an ILD consult, is this patient has this upper lobe fibrosis with traction bronchiectasis. It's very dense. There's a little bit less on the other side. Let me show the coronals. And this, I remember, it's taught a lot in studying for boards. Residency is upper lobe fibrosis. Think of Ank-Spon, but I mean, over all the years, I've never come across a real case. But this patient indeed has this. It kind of looks like pleural parenchymal fibroelastosis. I don't know if that actually is, but it's that distribution upper lobe. You can see the left upper lobe is less involved. And this actually had been stable over many years. I think we had a CT from 5 years back that showed stability to this. And you can see he's not very kyphotic, so he fused more upright, which of course helps with respiratory function. But I don't know if it's related or not, but it's talked about. I think Ank-Spon's probably managed much better nowadays, so maybe that's why we don't see it. But I don't know, David, have you come across a case like this?
No, but I've been wishing for it for almost 50 years. So.
Okay, so there you go.
It's one of those textbook classics that you never see.
Right, which makes you wonder if it always made me wonder if it was really a real phenomenon at all, or if it's just because they were so kyphotic, those lungs just weren't unhappy.
Right.
But yeah, I mean, you can imagine with the fusion, he's got some restrictive physiology, but it's not that bad. So ankylosing spondylitis with unequivocal fibrosis, whether or not it's related, it's interesting. What is interesting is in the discussion is this is really a different disease process than like a lot of the other autoimmune diseases, in that like there's really no role for anti-inflammatory that we know of. There's no role for anti-fibrotics, at least at this point. It's not the same kind of process there. So that was a rheumatologist had brought this for discussion, and at this point there was no recommendation other than to manage his current symptoms. So, all right, well, that is all I came across this week. I can stop sharing. I think that's everybody. So a little shorter session, but we'll commence again next week. So thank you, everyone.
Thank you.